proud to present my dear colleague, Professor Ayman Abu Noor. Professor Ayman is the Professor of Obstetrics and Gynecology and the former head of the department. And he started a project with Leuven University, which was completed later on by Professor Amr al-Husseini. We're starting a fetal intervention unit in collaboration with Leuven University. And we are happy to start with Professor Ayman's talk.
Okay, Assalamu alaikum. Now, we're going to talk about the establishment of the unit. I'm not a fetal medicine specialist, but I was, during my tenure as head of department, we started this project. So let's look at it. Now, the problem is that we have something we call twin-to-twin transfusion syndrome, which is a very dangerous and life-threatening condition. All right? The prognosis is very bad, and it represents about 10% of monochorionic twins, 6% of monoamniotic twins. This could be an underestimation, and probably is, because these cases are usually hopeless in Egypt. So most of them die without being counted. So we would count it about 1 to 3 per 10,000 births. In Egypt, we have around 2 million births. So 2 million, roughly about 600 to 1,000 cases per year of these cases. Now, this is from our Census Bureau. So we say that we have 3% of births are twins. 1/3 of them will be monochorionic. So we have about 1,250 cases to 1,850 cases. So around 1,500. These are all estimates. We do not really know the actual numbers. So we have 1,200, say 1,000 patients who are hopeless. We have 1,000 patients per year who are hopeless. Now, what is the management of these cases? In stage 1, which is minor, we just do amnioreduction, and this is available in Egypt. Stage 2, 3, and 4, we need to do laser. We need to do laser to laserize these vessels to prevent the condition from progressing and causing either death or major neurological damage. Stage 5 is probably nothing you can do. Now, this is a case of twin-to-twin transfusion. Both babies are at massive risk. The baby on this side, the side near me, is very pale anemia, which can cause death or mental damage. The baby on the other side is polycythemic, has an equal chance of dying or having major neurological deficit. Now, this is a picture of what happens to the brain in these cases. Massive cystic damage to the brain. In both pictures, this is massive encephalomalacia. These are hopeless cases with major neurological damage as one of the sequelae of this condition. Massive cystic damage to their brain, massive. The problem is these babies are alive, but are hopeless. The brain tissue is massively destroyed. The mortality of untreated TTTS is 50 to 90%. It is more than the most severe malignancy in the body. So it has a massive death rate. And even the patients who survive have around a 50% of major neurological damage. So if we have 1,000 cases a year, 50 to 90, 500 to 900 would die. The rest would have major neurological damage. The morbidity is multifactorial. Prematurity we cannot totally prevent, but the others, hemodynamic instability, hypovolemia, hyperviscosity, death of the twins, we can treat. So we can probably manage most of the conditions which leads to this dismal prognosis. Now, if we look, do we need the treatment? Because we are going to provide an expenditure for this treatment. Now, in cases of twins, prematurity is common, but the survival for fetuses will improve from 35 to 65%, single fetus up to 90%. If we do a laser, the number of cases with damage to the brain will be reduced from around 50-60% of the living cases to 2 to 10%. So we have a cure rate or an improvement rate of about 70 to 80%. The thing about it, it's higher in cases in which there is a recurrent case. So when we were going to establish the unit, we had to go for the best people so that we would reduce the need for recurrent treatments. So we have a big problem. The condition is dismal, all right? We don't want to treat it inferior, so we had to go for the best. The treatments we have, severe cerebral lesions are related to neurodevelopment. The outcome, if we have only 2 to 10%, we will improve. Okay. The problem is prematurity will remain a problem, but we will improve the other things. The other thing about it, that the cardiac function will improve after laser surgery. Now let's go to the politics. How many functioning fetal therapy units are present in Egypt? 0. One unit in Cairo University, they tried to establish a unit and they had maternal deaths. Why? Because it was established without proper preparation. So we have said we are going to provide a functioning unit with the expert care, and we are going to go for the best people to help us in setting up this unit. So we tried to establish the first twin and fetal intervention center. We are going to look about the project, the goals, the need, and the stages. Why do we need it? What should we do? And how would we? Why? We just said it. We have no functioning units in Egypt. 0. We have none. So this is the only. We have 1,000 cases a year, and we have to do something about it. What can we do? In addition to the twins, we can treat structural abnormalities, cardiac arrhythmias, fetal metabolic diseases, abnormalities. So actually, we are not only going to treat 1,000 patients a year, we are going to treat thousands of patients here. The neural tube defects in Egypt are around 11,000 a year. So if we progress to treating neural tube defects, they're around 11,000 a year. So many of these, without treatment, would have a dismal prognosis. Now, this is one of the things we are going to do. We're going to do treatment of twin-to-twin transfusion syndrome. One baby takes the majority of the blood, the other baby has been. Okay, this is what we said. No treatment, 90% death, 50% morbidity. Treatment, 67% survival instead of 10%, and most of them could turn out okay. As we said, we have to treat with fetoscopic laser ablation. This is a grade A recommendation. Now, let's suppose we are going to outsource the treatment outside Egypt. The estimated cost is $40,000. If we are going to treat 1,000 patients, that would be $40 million a year. All we need is about $200,000 to set up the unit, and the maintenance of the unit would be very easy. And we have had good communications with people, so it is cost effective. We are going to treat with less than 1% of the cost. Less than 1% of the cost. Okay? But we do need experience and expertise. So we made an agreement with Leuven University in Belgium. They are very experienced in these cases, and we had talks for about 3 years. Very tedious, very long talks. So our goal is to have a national regional referral center. We're not going for the university. We're going for the whole country. It is not a university center. It's going to be for the country and for the whole Middle East. The whole Middle East, we are going to help Middle East and North Africa, probably, if we establish it well. Okay? We're going to set up a multidisciplinary team of experts and educate. These are our major needs. We have the laser machine, the introducer set, the fetoscopies, the coagulation software, ultrasound. Setting up the unit will cost around $200,000, $150,000, $200,000, which is almost nothing. The stages, we had to have training over there, and we sent one of our very nice doctors to get trained over there. We signed a memorandum of understanding. We are now in the stage 2, preparation of the unit, and we already have the funds needed. We are just buying the equipment and setting it up. And then the third stage, which we hope will be effective within a few months, that we will get people from Leuven University, and we have other people from other areas in the world which might come and help us too. And they will be doing the cases initially and helping us to learn until we have the sufficient expertise. And it's going to be a two-way program because they do 20 or 30 cases a year. We expect 600 a year. So both sides will benefit. They will benefit, they can train more people, their publications are going to be better, they're going to be more experienced, they can do much more, and we are going to benefit. We're going to treat people, we're going to train people, so it's a win-win-win-win situation. winning for everybody involved. Okay, now these are other procedures we can do. Bladder obstruction, anemia, intrauterine transfusion, these are other things we can do. Okay, congenital diaphragmatic hernia, and I know some speakers will talk about it, spina bifida repair. We have around thousands of cases of spina bifida every year. All right, so this is going to be a further development here. Now this is our ambassador, Dr. Maya Abdurrazik, the first one who we sent, and she was the unanimous choice to send over there. And this is, I think, Dr. Elizabeth, which is going to be the director over there. All right, this is Dr. Maya. She is now training people, helping them out. And this is Dr. Maya with other senior staff. Beside Dr. Maya is Dr. Jen, which is head of the department over there. The other people that are involved are the senior people in Egypt, but actually it's going to be the younger generation who's going to do everything. Thank you very much. Thank you.
Thank you very much, Professor Ayman. We will postpone any discussion till the end of the session.
So the next speaker, Professor Dr. Ayman Shaban, who will talk about the prenatal management of complex MC twins.
Assalamu alaikum. Thank you very much. Good afternoon. Thank you, Dr. Ayman. You made my talk much easier. We'll talk a little bit about monochorionic twins. I have 15 minutes, so I will go very quickly. And thank you, Dr. Ayman, made it a little bit easier for me. So I'll try to cover a discussion about twin-twin transfusion and selective growth restriction. These are the most common diseases we deal with. And if we have time, we'll talk a little bit about twin reversed arterial perfusion. Twin-twin transfusion, as you heard, there's a recipient and a donor. They have opposite physiology going on. You have a recipient that's hypervolemic and hypertensive, and a donor that's hypotensive and hypovolemic. And roughly occurs in 1 in 6 or 1 in 7 monochorionic pregnancies. It's a disease of the second trimester, and early gestational onset is obviously more severe. And as you heard, if you don't treat it, there's 100% mortality and morbidity, prematurity, neurologic deficits, all the things you just heard. I couldn't agree more. It's a disease caused by arterial to venous anastomosis in the placenta. Here you can see the placenta. It's a connection between the artery and the vein causing the disease, as well as balancing connections, arterial to arterial and venous to venous. Here is an example of a balancing connection. You'll see, let's see. Yep. Maybe you can see here the artery to artery back and forth. We call it the harlequin. You can see the blood going back and forth. These are balancing connections. In the absence of these balancing connections, twin-twin transfusion is much more common. It's also a disease of hormonal sharing. The fetuses, as I said, have opposite physiology. One is hypotensive, one is hypertensive. They share hormones, hormones produced by the fetus, hormones produced by the placenta. All of them you can see here. I won't go into it, but these are also complicating disease, causing cardiac disease. The diagnosis is made by the observation of oligohydramnios and polyhydramnios in stage 1 disease. Stage 2 disease, the donor bladder is lost. Stage 3 disease is when you start to see Doppler changes in the recipient, primarily venous changes, umbilical vein changes, or absence of the A wave or reversal of the A wave in the ductus venosus. And in the donor, for stage 3, you start to see abnormal UA, umbilical artery changes, absence or reversal of the umbilical artery flow. This is the Quintero staging system. I think you all are very familiar with it. There's also this is a disease not just of fluid, this is a disease of cardiac physiology, of cardiac derangement. The recipient cardiac disease is severe. You can see the cardiomyopathy. We term the cardiac, the hypertrophy and the valvular disease as cardiomyopathy. You can see it described here. We use the myocardial performance index as an objective measure of cardiovascular disease in the fetus. And using the Cincinnati staging criteria as mild, moderate, and severe, you can see the MPI numbers as well as the observations subjectively of mild, moderate, and severe disease. Putting these together, this is our treatment algorithm for patients with twin-twin transfusion. We offer laser surgery for any disease, stage 2 and 3 and 4, advanced stage disease. and any patient with severe or more than mild cardiomyopathy. For stage 1 disease, the primary treatment is expectant management. However, sometimes we offer laser surgery for, like I said, advanced cardiomyopathy. Perhaps the patient has massive polyhydramnios and starting to have cervical shortening, or the patient may have poor access to medical care, cannot come back and forth for monitoring, and sometimes we offer laser surgery for stage 1 disease in this situation. The surgery is it's an interesting surgery. It's a local anesthetic, typically local anesthetic. It's an entry into the sac through the abdomen of the mother under a local anesthesia, and then the scope is entered, and you can see you're able to visualize the placental surface, and you can identify the anastomoses and map them. And then once we've finished the mapping, we just fire the laser, as you can see there, to ablate the vessels on the placenta. Here's the actual video of the procedure. You can see the recipient fetus here, about 16 or 17 weeks, just quietly waiting. You can now see the laser, and you see the arterial venous anastomosis here. It's a causative anastomosis, and you'll see the laser, how effectively it treats and ablate these 1 or 2 millimeter vessels. And some of them are smaller, and some of them are even bigger. But the laser is a very effective therapy. It's a diode laser, typically at 15 or 30 watts, depending on the disease. It's very effective even for the larger vessels, as you see here. It's an amazing technique. I wish I invented it. I did not invent it, but it works very well. This is the outcomes for laser surgery at our center for twin-twin transfusion. You can see here we have about a 92 to 95% survival of at least one twin from the surgery through the rest of pregnancy and then discharge. 75% survival for 2 twins and about 84% overall. Average gestational age of delivery about 31.5 weeks, so latency is about 10.5 weeks. Lots of things to study in this disease. This treatment is a good treatment, but it's not perfect. Some of the things to study are listed here. Understanding developmental outcomes, not just survival, but what kind of children we're going to have, what kind of adults we're going to have after this disease. Understanding the treatment of some of these very complex situations that you see here. Understanding better biochemical and molecular sort of markers of disease to help us understand the therapy and to guide the therapy in a better way. Selective growth restriction, and I'll go very quickly here. Growth restriction is a very difficult problem. We see so much of this, and I'm sure you see it as well. There isn't a perfect treatment, but more importantly, the diagnosis and the predictive capacity of our tools are very limited in selective growth restriction. We've adopted the Delphi criteria that you see here on the right for diagnosing the disease. We use the Gratikos staging, the type 1, 2, and 3 as listed here, where the umbilical artery diastolic flow is either preserved intermittently or absent in a fixed way or intermittently. And I'll let you all learn about the Gratikos staging. The usefulness of the Gratikos staging is in predicting the severity of the prematurity and the morbidity and the mortality. So you can see here for Gratikos 1, well, you can see the yellow is Gratikos type 1, the purple is type 2, and then the red is type 3. The gestational age at delivery is obviously much less for Gratikos type 2 and type 3 and better for type 1. Gratikos staging also predicts the mortality. You can see the mortality here for type 2 is very high, the odds ratio compared to type 1s. And then also other findings like oligohydramnios and an absent or abnormal Doppler in the ductus is another predictor of poor outcome for the growth-restricted twin. Rami Chmate in Los Angeles has developed a subcategorization for type 2s, type 2A and type 2B, and shown that we can operate now on type 2 with not just a uniform loss of the growth-restricted twin. There's actually a roughly 50% survivorship for type 2A where the ductus venosus is preserved, where it was thought before that the donor would always be lost. The type 2B donors have no particular capacity for survival. So survival with dichorionization in type 2 disease is possible. Now the operations that we use for selective growth restriction are different from twin-twin transfusion. Twin-twin transfusion, we target the connections. You can see them there in red on the left. And then with selective growth restriction, we do a dichorionization where we target the connections and then we laser between them. It's a so-called Solomon technique to completely dichorionize and creating two physiologically separate placenta. Lots of things to study in this disease here, specifically the diagnosis and the treatments really are just evolving for this disease. Surgery is not the primary treatment for this disease. Observation and early delivery and surveillance are the primary therapies for the disease, but there is a role for surgery which is evolving and hopefully we'll have better answers in the future. I'll spend the last couple of minutes talking about twin reversed arterial perfusion sequence, or TRAP. TRAP is very rare. I'm sure you see them here a lot. There is a perfused twin and a pump twin. Perfused twin has no heart, typically has no brain or no head, but it is receiving its blood flow in reverse through the umbilical arteries, going back to the twin, so the name twin reversed arterial perfusion is based upon that. The pump twin has a risk for high cardiac output failure and death of that twin. Prematurity is also a possibility. Those risks go up when the ratio of the size between the pump twin and the perfused twin is roughly about 70% or higher. And there's a calculation, as you see here, that can be used to estimate the weight of the perfused twin. There are variations in the anatomy. Typically there's legs and there's a torso of some sort, but very frequently there's absence of the upper torso and the head. But the TRAP is always acardiac. The treatment, by and large, for diseases in which the perfused twin is small is observation. Serial echocardiography, observe fluids, and observe the twins for growth, the healthy twin for growth going forward. However, if the pump twin starts to develop high cardiac output physiology or polyhydramnios, or the size ratio encroaches upon 70%, above 0.5, then those patients are candidates for cord ablation. In the setting of when the twins are together in a monoamniotic setting, we always perform not just cord ablation, but cord transection as well. We use an RFA approach. There's microwave, RFA, bipolar, a variety of different techniques here for cord coagulation. It's an intracorporeal coagulation, actually within the perfused twin here. And then for the case of the monoamniotic twins, we will actually perform a cord occlusion and division because of the risk of entanglement. The risks of entanglement go up after the pump twin, the perfused twin has passed. It creates a as you can see on the right side, you can see the acardius there, the very small acardius, has a very thin, we call it fishing line type of umbilical cord that causes strangulation and unfortunately caused death of the pump twin. And that's it. That's all you need to know about monochorionic twins. I'm happy to answer any questions, and thank you, Dr. Maya, for the invitation and for the hospitality here.
Continue with Professor Dr. Ayman. Next talk will be about the pediatric surgery exit procedure.
Yes, please, Dr.
Okay. Very good. I'll just go ahead. It's okay?
Yes, please.
Oh, yellow. Okay. So I'll talk to you about exit procedures, exit to airway procedures for congenital disease. Exit procedure is not a cesarean section. It's a different procedure. And I understand that you are doing exit procedures here at Anschem's, so this will be sort of a discussion more than a lecture. Cesarean section, we try to maximize the tone. In an exit procedure, we want hypotonia. In cesarean section, we try to minimize fetal anesthesia exposure. In an exit procedure, the fetus is completely anesthetized. So it's a different approach entirely, and the risks also increase for the mother with this treatment. The indications for an exit are listed here. They are the exit to airway, the exit to resection, exit to ECMO, and exit, even if you can believe it, for fluid production, inversion of the diaphragm, hydrops, ascites, scalp edema, all these things simply from an obstruction at the level of the glottis. Here you can see on the MRI, you can see the fetus with ascites, very large, lungs with inverted diaphragm. You can see the liver floating in a sea. of ascites. Here again, on the ultrasound, you see the heart surrounded by very dense echogenic lungs with an inverted diaphragm and massive ascites in the patient. For an exit procedure, the mother is under general anesthesia. She has a few things that are different than a regular general anesthesia. She'll have an epidural in addition to the general anesthesia. We have a deep inhaled anesthesia that we transition to a desflurane or sevoflurane deep anesthesia. The fetus will have a pulse oximeter, and then we use a stapled hysterotomy, which is also specially designed for these procedures, and a amniotic infuser of lactated ringers to maintain amniotic fluid volume. This is the standard approach. Here you see through a transverse incision the mother's abdomen, and a laparotomy. You see the exposed uterus. Ultrasounds used to map the placenta, then a controlled hysterotomy, avascular controlling the membranes, using the stapler to create a very nice stapled controlled hysterotomy, no bleeding. You see the fetus is being delivered, the head is being delivered, pulse oximeter applied, and then now you can see an adjunct anesthetic. We call it a cocktail, vecuronium. We include atropine and fentanyl in the cocktail. And then this child has chaos and would have to have a tracheostomy. Here's the tracheostomy being performed. You can see that the fetus is very well perfused. One of the fetal surgeons is protecting the umbilical cord to prevent compression. There's bleeding, it's quiet, there's control, there's time to do whatever you need to do safely. Once that's done, fetus is delivered and then handed to the team for the care. We've used this for exit to airway for cervical teratomas. Cervical teratomas are masses of tumors, germ cell tumors that grow very rapidly, and very importantly, they compress the airway. Here you cannot see the airway because the tumor is displacing the airway or compressing the airway. Here's an example of an exit procedure for a teratoma. These are not subtle tumors, they grow very rapidly. This is a fetus here, roughly around 34 weeks gestation, massive polyhydramnios, very large tumor. Again, you can see the fetus is well perfused, the hysterotomy is controlled, no bleeding, all under very good control. Intubate the fetus, bronchoscopy, tracheostomy, whatever you need to do, then deliver the baby, take the baby to another room, resuscitate, and complete the resection. You can see it's a very large tumor, very invasive. You can see that it goes behind the trachea, the carotid, the jugular, thyroid, everything is there. It's resected. The airway is now stabilized. This is that baby, that same baby that you saw. She's perfect. She's naughty. She runs around. She creates trouble for her mother just like every other girl. So just a very stable operation for a very bad situation. We use it for exit to airway for lymphatic malformations less frequently. Lymphatic malformations, as you know, don't typically compress the airway. Typically the airway is patent. You can see the airway just here on these images, here on the sagittal images, and less likely for it to be compressive, more often insinuating through the tissues and the submucosa, sometimes involving the hypopharynx or the floor of the mouth. But the airway is typically patent. Typically you'll see the airway like this on the left. The landmarks are clear. You can see the glottis very nicely, the vocal cords, the arytenoids. Putting the tube in, you can see it's very clean, very easy to see. Sometimes these are very insinuating, infiltrating tumors. And these ones are very difficult. You see sometimes hypopharyngeal involvement or floor of mouth involvement. And then when you go for your laryngoscopy, the landmarks are not clear. And sometimes they are horrible. And this is an example, it's rare, but this is an example of, you can see the endotracheal tube. The grayish structure is the vocal cords. You can see the landmarks are completely unrecognizable. So sometimes this occurs whenever you have hypopharyngeal involvement or floor of mouth involvement. Beware of the exit for these particular procedures. An exit's a better idea than just a simple cesarean. Sometimes we deal with oral masses. This is a simple mass. It's a duplication cyst of the tongue. It looks like this. Very straightforward. Laryngoscopy, intubation, very straightforward. Sometimes the masses are more significant. This is an epignathes, a teratoma. From the roof of the mouth, typically it's on a small stalk, but you can see here it creates an impossible situation here for delivery. You can see we performed a tracheostomy. Again, took the child to the next room, completed the resuscitation, and took the tumor out. And that this baby, you wouldn't believe how well she looks today. Looks fantastic. And her mother never saw that tumor. She never saw that tumor. Now, some cases, we can do something smaller. Instead of an exit procedure with general anesthesia, we can do something called procedure on placental support, or a POPS procedure. It's like a cesarean section, but we give a dose or two of nitroglycerin to help assist with the prolongation of placental support. Use it very frequently for microanathia. Here in the Pierre-Robin sequence, we see it. And with this disease, unfortunately, you'll see glossoptosis sometimes in a cleft, obstructing the airway. With the small mandible, makes it very difficult to get an airway, even an LMA or any type of airway after birth. Some of these patients benefit from a POPS procedure, which the mother is awake, but it's a little bit more than a cesarean delivery. We use the jaw index and different craniometrics, inferior facial angle, nasal-mental angle, different angles to actually predict the severity of the disease. The jaw index is the one with the most validity. And you see a jaw index here, the calculation. Jaw index less than 21 is typically an indication for a POPS procedure. And these are not for the mild microanathia. These are typical babies with severe microanathia that we see that have glossoptosis and airway obstruction. And we can do a tracheostomy in 10 or 15 minutes of placental support and take the baby out, and then the plastic surgeons and the ENT surgeons can work on the jaw advancement and the distraction over the coming months. Going forward, there are a lot of efforts to improve what we do to reduce the severity or the morbidity of an exit procedure and transition more to a POPS procedure, which is more like a C-section in terms of morbidity and long-term outcome. So taking this has been done for chaos, and I'll show you an example of it, and it helps also to improve the physiology before birth. Some of the chaos kids still have the high drops at the time of delivery, and their physiology is so abnormal they have a very poor survival. If the high drops resolves before delivery, their physiology is better and they have a much better outcome. So some investigators have, and us as well, have used the laser or a needle or a balloon to actually fenestrate the airway prior to delivery, especially in the babies with the severe high drops. And the idea is to simply identify the cord and the cord structures, and to use either a laser or a needle to make a hole, to pop through, to decompress the lung fluid, and it reverses the physiology. Ideally, if this is not spontaneously occurred by 30 weeks or 32 weeks, one of these procedures may be helpful. That can reduce the severity of the disease, improve the outcome for the fetus as well. And this is an example of that. This is you can see the high drops on the imaging, and then you can see the balloon therapy to perforate the membrane and then to use the balloon to expand the hole to keep it open. In the future, we hope to have better, more rigid or more structured indications for fetal surgery. Right now, it's based upon expert opinion at each local center. There's an ongoing effort from the North American Fetal Treatment Network with the Delphi survey to have an exit registry based upon the results of the survey. We'd like to transition from exit procedures to POPS procedures with the use of pre-delivery interventions, using other treatments that may be adjunct, such as HIFU, or the use of sirolimus prenatally to reduce the growth of the lymphatic malformations to help improve the airway. Always trying to improve the quality of the imaging of the airway and to identify new biomarkers of disease that may predict the severity of the disease, as well as the physiology that may exist, because after the baby's born, you still have to deal with the baby's sickness. So this is the future. Hopefully, we'll see this happen in the coming years. This is our motto for these diseases. Teamwork makes the dream work. There is no question here. You need a very close team that understands what each one's role is, and you can work together in a seamless way, ensure that every one of these babies has a smooth transition. The mom is safe, the baby is safe, and everyone is in a comfortable position. Thank you very much. I'm happy to answer any questions, I guess, at the end.
Thank you very much, Dr. Ayman. Dr. Ayman is a vast experience in fetal surgery, almost 3 decades now, from Iowa to Philadelphia to Cincinnati to Chicago now. So that's a great addition to our commencement with this oasis that's started by Professor Ayman Abu Noor. So we are now having two Aymans in the fetal surgery in Egypt, Ayman Abu Noor and Ayman Shaban. And I would also like to welcome our dear friend Carlos Gené, Professor of Pediatric and Fetal Surgery in Barcelona in the Vall d'Hebron Teaching Hospital.
Thank you very much. Thank you very much, Mohamed.
Thank you very much.
I want to thank the organizers and chairman for the invitation. I'm honored to be here. And dear colleagues, we'll talk about our experience in Barcelona in our fetal team, but I want to start with a little exercise. I'm a pediatric surgeon, and I want you to introduce to this very patient of mine. It's Carlitos. It's fake name, but it's a real patient. It was born prematurely at 23 plus 5, and very small. And he had an ischemic intestinal perforation, right? And on the other side, we have another patient. It's Joselito. It's a little bit older. It's 24 plus 2, and it's still a fetus. It's still in the uterus, and he has a melomeningocele, right? So they both need surgery. So for the Carlitos, for the premature, we have to do a laparotomy, intestinal resection, and anastomosis. And look, we can control a lot of things. Now we can do an esophageal intubation, put some venous lines, monitor properly, heat control. We can have tests and blood tests, and we can give him intravenous anesthesia. But what happens with the myelomeningocele, the Joselito? We have to do a fetoscopic two-layer closure, but we cannot control almost anything of this, right? So this is an example to know that the fetal patient is nothing to do with the neonatal or premature patient. We can count on the maternal-fetal circulation, the heart rate monitoring. We can have control of the heat and intramuscular anesthesia, right? So which are the general principles of a fetal intervention? We have the fetal medicine is when you include the fetus as a patient. And we have, in fact, two patients, the fetus and the mother. And we talk about fetal therapy when we do something invasive to the fetus, right? In general, the fetal surgery criteria is isolated malformation, but nowadays it's controversial. Well-known natural history of the malformation, and the intervention has been proved beneficial for the fetus. No? So we have to check this out with complementary explorations. How is the surgery inside the uterus? It's particular. Some particularities makes it particular. The membranes. The membranes, I imagine the membranes like a balloon. It has no blood vessels, so they don't heal. So the hole you place in the balloon will stay the longer the gestation is, right? And it grows differently from the myometrium. So we will deal with some complications like detachment or premature rupture, right? Myometrium, it enlarges a lot. The muscle cells stretch and hypertrophy. We have an increased number of blood vessels, and reacts to manipulation, contracts. So the complication we can expect are bleeding, rupture, preterm contractility, or acrotism in further pregnancies, right? So in general, when we do an open fetal surgery, we will have to deal with problems with the myometrium mainly, and with minimal invasive surgery with the membranes. So we have to take into account the maternal-fetal circulation, right? We have to be very careful about the drugs we give to the mother. And the environmental conditions are particular. The fetus is heated. He needs to be heated. It's very important, the heat. For these patients, the amniotic fluid, he's swimming in amniotic fluid. We have very limited space, and therefore show room for the resolution of complications. So principles: we don't touch the membranes when we do a fetoscopy. We use humidifying heater systems, limited number of ports, the lesser the better, and we manipulate the uterus very gentle for the contractility, right? So which are the main conditions, the evidence-based indications? Monochorial gestation disorders, you know a lot, thanks to Professor Saban. Malformative conditions, congenital diaphragmatic hernia, low urinary tract obstructions, pulmonary malformations, etc., neural tube defects, and evolving conditions, as you saw in the previous lecture. So which kind of procedures can we offer, and we offer in Barcelona, like in many other places in the world, open fetal surgery, fetoscopic surgery with the uterus out or completely percutaneous, depending on the condition. Sonographic guide procedures, a lot of them, and exit procedure. So, as you can see, there are many people, many different profiles implied in this team, because there are many different kinds of malformations. And the fetal surgery unit normally is what we call a village people. They are very different profiles, and sometimes it's the most difficult part of the team to join them together for a common goal, right? And I'm a pediatric surgeon, so why is it so important to have a pediatric surgeon in the team? Because we have knowledge in embryology, and we have knowledge in the natural history of different malformations. We have surgical skill in open and minimal invasive procedures. We have endoscopic skill as well for the airway and for the digestive tract. And we take care of these patients afterwards. In my center, in Europe in general, we are not much involved in diagnosis and in intrauterine follow-up. And we have low knowledge in several conditions like monochorionic twins or cardiologic procedures or uterine complications of postoperative follow-up. That's why it's so important, the obstetrician part of you. In the States, it's a little bit different. As you have seen, the pediatric surgeons take care of many of these conditions as well. So what do we do? CDH, amniotic bundle release, luto, exit procedure, open resection of pulmonary malformations, teratomas, neural tube defects is my favorite, and pericardial is very, very seldom. Other indications done in our institution, mainly by the obstetrician and cardiologist, is laser therapy for TTTS, thoracoamniotic shunt, and other procedures for monochorionic conditions, diagnostic procedures, and cardiologic procedures. So I will just make a quick overall of these conditions, the more frequent. I won't talk about that because of the outstanding lecture of Ayman. So the twin-to-twin transfusion syndrome, 2 patients, 1 placenta, communications, and depending on the condition, we can offer the laser coagulation, like in this case, or we can offer the occlusion of the cord that we do percutaneously, guided by ultrasound with an energy device, forceps. So congenital diaphragmatic hernia, I won't talk too much about that because you will have a lecture on that topic in the next session, and I won't do a spoiler. But in overall, when the bowel of the baby it's going inside the fetus again, physiologically at week 11, 12, if you have a hole in the diaphragm, the bowel goes up and compresses the pulmonary tissue. And the maturation of this tissue is impaired. So we end up with a pulmonary hypoplasia and a pulmonary hypertension. That is the biggest problem of this very baby. So from the experimental point of view, we discovered that if we occlude the trachea in different stages of the lung development, we will have an hypertrophy of the lung tissue, right? So our current strategy is to plug the trachea around 26 to 27 weeks of gestation and unplug it 6 to 8 weeks later. This is the plug. You will see that in the next session with more detail. And why we take this out? Because it's been proved that with the unplugged, you regenerate the type 2 pneumocytes that are responsible for the production of surfactant. It's very important for the baby when it's born, and allows the clearance of the secretions. Cardiologic procedures. They are done in my institution by the cardiologists with the obstetricians. We are dealing with aortic stenosis and pulmonary stenosis. Aortic stenosis when we have a non-hypoplastic left ventricle. The pulmonary stenosis have more restrictive indication. But the goal is to increase the opening to go for a biventricular heart, right? So the procedure is done percutaneously. Well, it's not working like it should. Okay. guided by ultrasound, and you place a balloon into the atretic stenotic valve and do the dilation, and you can finish it up when the baby is born if it's needed, like in this case. Amniotic band release. We have bands from the amnios that surrounds an extremity and the umbilical cord or any other part of the body with a mechanical progressive strangulation that can lead to amputation. So we developed the experimental model of amniotic band syndrome and brought it to the clinic. And in this case, we are using the laser to cut the amniotic band. Okay, low urinary tract obstruction. It's kind of disappointing for me. It's a malformative spectrum with a difficulty of the output of the urine. And we start with a megabladder, hydronephrosis, and kidney damage with renal insufficiency. Right? There are several causes. The most frequent is the posterior ureteral valves. Very little room for the indications of fetal surgery. We need good kidneys and good renal function. And we have many options, but the two real options are the vascular amniotic shunt and the fetal cystoscopy. In our institution, we are doing the vascular amniotic shunt, but with plenty of complications. And in other institutions, these are images from Rodrigo Ruano, are doing fetal cystoscopy. They put a fetoscope in the bladder and coagulate the posterior ureteral valves with a lot of complications as well. Again, another lecture will be done in the next session about that, so I won't extend that much from that. We can deal with these complications in an exit fashion if the baby is big enough. Or we can put a thoracoamniotic shunt when needed. You will have all the details this later on. Exit procedure, you know everything again, so it's going to be quick. This is the indications. At the beginning, we use that to take out the balloon from the congenital diaphragmatic hernia. We are not doing this anymore. And the same as you saw, we can do a tracheostomy, we can do the intubation, we can puncture the cyst and do the intubation. And neural tube defects is my favorite. You will have another lecture later on. And we have the leakage of cerebrospinal fluid with hindbrain herniation, hydrocephalus, and a direct injury to the placoid because of the chemical action of the amniotic fluid and the mechanical action of uterine walls, right? So what we intend is to close the defect to avoid the leakage and to protect the neural tissue. And what we do in our hospital is the 2 layers closure. And this is a small video where first we try to dissect the neural tissue from the surrounding dysplastic tissues. This is a myelomeningocele, has a cyst. This is a myeloschisis, don't cyst, but it's the same procedure. And then what we intend, something went wrong. Okay, let's edit that. This is another case of myeloschisis. And then we do the subcutaneous dissection and close the myofascial layer. We put a patch over the neural tissue to avoid the attachment to the myofascial layer. This is another case. And then the skin. Normally the skin reaches very well, but in cases of mainly myeloschisis, you have a huge defect of skin and you need to do something else. Oh, thank you.
Thank you so much, Professor Carlos, for the remarkable presentation and the vast experience in fetal surgery. From a neurosurgery perspective, I was really fascinated with fetoscopic repair of the myelomeningocele. I would like to present Dr. Hani Ahmad, a dear colleague and friend, part of the team of the pediatric surgery. He's going to present to us his talk about neonatal abdominal wall defects.
Okay, thank you, all the chairpersons. Thank you for all the speakers for their fruitful presentations that I learned a lot from. Today I will talk about the abdominal defects, a small review. Okay, abdominal defects is one of the common congenital anomalies. Gastroschisis and the omphaloceles are the most common types. Their prevalence about 1 in 3,000 to 1 in 4,000 live births. Although they are both abdominal wall defects, but they have different pathology. Okay, we'll start with the gastroschisis. The abdominal wall defect is usually to the right side of the umbilicus, with no covering sac to the viscera. And the most accepted theory that there is early involution of the umbilical vein and failure in the development of the ventral body wall and herniation of the viscera. Gastroschisis is not usually associated with other anomalies unlike the omphaloceles, so the postnatal outcome is mostly dependent on the degree of the intestinal injury. So antenatally, the diagnosis is mainly more than 90% of the cases, identification of free-floating intestine with no covering sac and with intact umbilical cord is diagnostic. Diagnosis is usually not reliable before the second trimester, but it can be after the 12 weeks after the regression of the normal physiological herniation of the midgut. Also, the elevated maternal serum alpha-fetoprotein is observed more than in the omphaloceles. Okay, once diagnosed, we need to do serial ultrasounds. There are different prognostic factors as the bowel dilatation, the polyhydramnios, the gastric dilatation, and also the intrauterine growth restriction. And I noticed that the fetal weight can be underestimated because of smaller abdominal circumference. Okay, and the timing of delivery is controversial. Some studies recommend that be between the 35 and 37 weeks gestation, but on the other side, some studies recommended to pass the prematurity and the delivery to be after the 37 weeks. Also, the mode of delivery is also controversial, but there is no solid data that there is evidence of superiority of cesarean section over the normal vaginal delivery. Okay, if you talk about the fetal intervention, there are some factors that affect the morbidity in gastroschisis. Exposure of the intestine to the toxins in the amniotic fluid, decreased volume of the abdominal cavity that make the repair after the birth is sometimes difficult. Also, the mesenteric ischemia due to the constriction of the defect. Antenatal intervention aims to prevent all of these factors. We'll start with the amniotic change or amnioinfusion. This idea is to lower the toxins of the amniotic fluid by injecting sterile saline. Multiple studies are done on the animals and humans. Animal studies show decreased rate of bowel inflammation with better outcome, and some human studies show decreased peel formation and inflammation of the intestine. But randomized control trial was held but aborted due to the increased rate of intrauterine death. So more studies need to be done. Also, the exit-like procedure, the defect is closed immediately after birth. The fetus is still on the umbilical cord circulation for taking the first breath to avoid the bowel dilatation. This technique has been adopted by many centers nowadays. Also, the fetal repair and covering is mainly done on animal studies. Open orthoscopic approaches by totally repair or just by covering the intestine. No major studies support the better outcome till now, but few human studies are being done on the endoscopic repair and pending results. In this case, this is a primary, this is a case report. It was done in Brazil. As you can see here, they are trying to return the intestine fetoscopically. And then they try to close the defect. In this case, it was done at the 35 weeks gestational age. But unfortunately, after 2 days, by following up by ultrasound, they found that the bowel loops herniate again, and they tried the exit procedure, and then the neonate was discharged after 2 weeks. Okay, we start with the postnatal. We have simple gastroschisis, as you can see here, that the intestine looks healthy with no covering peel, and this inflamed slightly more than the previous one. And when we go to the complex gastroschisis, we can see here that there is increased inflammation and some sort of intestinal atresia. Also in this picture, we can see the increased peel formation. Here there is an ileal atresia. Also, this case is a case of closing gastroschisis that affect the blood supply of the herniated bowel. And as you can see in this case, this is a severe type of gastroschisis, and this neonate had been died shortly after birth. Okay, we'll talk about the management. First of all, to secure the airway, the heat management is so important. Cover the intestine with hot saline gauze, and to wrap the neonate with plastic sheets. Also, the maintenance fluids is so important. The nasogastric tube to deflate the bowel. Then inspection of the bowel to detect any associated complications. Of course, antibiotics, and then proceed for the coverage. Okay, then we'll go to the types of closure. The primary closure. We look to primary reduction and suture the closure in the operating room under general anesthesia, like in this patient. Sometimes we can do the sutureless closure. It has been done in the last decade. In this case, as you can see here, we use the umbilical cord to cover the defect, and just putting a tegaderm on it, and this is the result after a few months. If we cannot do the primary closure, we go to the stage closure with this silo bag. As you can see here, this is a traditional silo that's not always available in our country, so we use our custom-made silo bag. So post-operatively, the patient should be monitored for any compartmental syndrome, monitoring urine output, and any signs of the compartmental. Also, afterwards, following up the nutritional status is so important, especially if the patient has short bowel syndrome. Next, we'll talk about the omphalocele. Omphalocele is different from the gastroschisis that is midline. The umbilical ring is covered with sac. So, to be failure of regression of the physiological gut herniation, there is many associated anomalies, up to 60 or even 70%. Prognosis is related to the associated anomalies, and it is divided also into major and minor. Can be diagnosed antenatally as herniated abdominal contents covered by 3-layer sac with the amnion, with the Wharton jelly, and with the peritoneum. Can be diagnosed after the 12th or 6th week. Karyotyping is so important to detect associated anomalies, and monitoring fetal growth. So, postnatally, we can see here, this is a minor case that's usually closed primarily. And postnatally, also this is a major case that there is a herniated liver in it. Also in this case, we can see that the stomach, the intestine, and the liver are herniated. So, management by initial resuscitation, as we have talked before. Also to exclude associated anomalies by echocardiography, ultrasound. Then we try for closure, primary repair, staged or delayed repair. So, in primary repair used usually in the minor types, We can assess the tolerance by careful bedside reduction. And of course, the umbilicoplasty is so important. As you can see here in this case, this is a minor type. Then the staged repair, we can use a mesh or a silo bag to accommodate for give more volume in the abdominal cavity to accommodate the herniated bowel. Then the tissue expanders also can be used subcutaneously or even intra-abdominal to give more volume for closure. Skin flaps is sometimes historical. That can be done to cover the major types. Also, recently, the back dressing is so important to help enclosure of the defects. In the daily repair, just the paint and weight, we can use the povidone iodine material or the silver sulfadiazine just to make an esker and then allow the skin to cover this amphilosoil and then lately we'll repair the ventral hernia, and this usually taken after 2 or even 3 years. Thank you.
And for our last talk in this session, Professor Asim Abdel Latif, Assistant Professor of Neurosurgery and Pediatric Neurosurgery, will be talking to us about adaptation of to moms, trial recommendations, fetal versus neonatal MMC repair.
Okay, good afternoon, everyone. I would like to first thank the organizing committee and the chairpersons for giving me the chance to share some thoughts on the fetal and the neonatal repair of the myelomeningocele. We see a lot of patients of myelomeningocele, and we are so much aware of the pathology. It's a defect of this secondary neurulation. It's not a defect of the primary neurulation, because most of the myelomeningocele that we see are in the thoracolumbar region, where we get I'm sorry. Where we get sort of the caudal mass, the caudal cell mass. It differentiates and it produces the terminal part of the spinal cord. As we can understand and go back to the basics of the embryology, the neurulation starts with the formation of the neural plates dorsal to the notochord, derived and stimulated by the notochordal factors or growth factors. Then this plate invaginates to form the neural cleft, and then it deepens to close on itself, producing the neural tube. Any defect along this way will produce sort of a spina bifida or a neural tube defect, but most of the time it's the open neural tube defect that we see at our institution, and we can appreciate that there is failure of closure or failure of neurulation at this stage. We conducted early on, about 10 years ago, a prospective registry on pediatric hydrocephalus to be able to direct the treatment of hydrocephalus, and we had very remarkable and striking results that, as we can see here, the Chiari type 2 was Chiari-type 2 was almost close to 30% of the cases of the hydrocephalus, the Chiari-type 2 associated hydrocephalus, and the post-infectious was just coming next with a 24% instance. We can deduct, or we can deduce from this that there is a huge, or there is a considerable incidence of myelomeningocele in our hospital, in our local institution, and these particularly compared to the reported incidents in some of the papers and reports coming from the US that there are close to 3 to 4 per 10,000 live births with ethnic and racial effect being more in Hispanic population and less in the African Americans. But what's really remarkable here is that this paper from the effect of the folic acid supplementation and the rate of the prevention of the preventable spina bifida or the open myelomeningocele, we can see that Egypt falls in the category of that there is no prevention. We get all the cases. That's why, hence, we have the very high incidence of myelomeningocele in the live births. What's usually done, and that's the care here in our institution is, and probably in Egypt, is the neonatal repair of the myelomeningocele. It aims at prevention of the infection, CSF infection, closure of the sac, prevention of further neurologic damage or further neurologic deterioration because the damage is present at birth, and ensure the best chance to avoid future spinal cord tethering. We need to put in mind while closure that we try to avoid future spinal cord tethering and address the associated hydrocephalus. So standard of care is to do early closure within 72 hours of life, which is usually not attained because of either local anesthetic factors, logistics, or most of the time it's the lack of awareness that this is an emergency condition or the reluctance from the neurosurgeons particularly to offer emergency treatment for these kids because they think that they are not hopeful patients. Whenever there's CSF leak from the sac, we could do an emergency closure, and the postnatal repair is a comprehensive team or multidisciplinary work by pediatric neurosurgeons, orthopedics, pediatric urology, physical rehab, and neurology or developmental specialists. And all this could be done under the umbrella of a spina bifida clinic. When we see these patients, we do the usual as the perinatal repair, dissect, do secondary neurulation, close the neural tube, close the dura and reflect myofascial flap, and then do either direct or rotational flap skin closure. But this ends up with something. There is highly possible neurologic damage. It's present at birth. The exposure of neurologic tissue in utero, as highlighted by in the previous lectures, provides also a risk for neurologic damage. And even the surviving patients would have major disabilities with bladder and bladder dysfunction, gait problems. Most of them are paraparetic, but they have intellectual ability. They have intact intellectual ability if they had hydrocephalus that was properly treated. Permanent shunting is usual in 50 to 80% of the cases, but so if we could do better, we could do the antenatal repair and this in theory and in practice it provides less exposure to the neural tissue and virtually no exposure in the postnatal period with shorter duration of CSF egress from the sac, and this particularly is important as it decreases the incidence of the hindbrain herniation and subsequently the development of hydrocephalus, or even it may result in the development of ventriculomegaly that is asymptomatic and does not require ventricular peritoneal shunt or CSF diversion. And most of the time they close directly. So in 2012 I attended the presentation of the results of the MOMS trial about the management of myelomeningocele study, which was published in the New England Journal of Medicine in 2011, and the study was a randomized controlled clinical trial that was conducted at CHOP at Vanderbilt University in Tennessee and at UCSF, with strict inclusion criteria of a single uterine pregnancy, single fetus, a gestational age at the time of inclusion from between 19 weeks to 25.9 weeks, which is probably the age of the fetal maturity or the fetal viability, that could, in case of preterm labor, they could be viable in a neonatal ICU, could be supported properly. Thoracolumbar myelomeningocele with evidence hindbrain herniation and the maternal age of more than 18 years. I'm highlighting these things because some of the strict criteria in the MOMS trial may be different from the patient population that we're facing here or serving here. Also, there were exclusion criteria in the presence of other fetal anomalies. That's understandable. Severe kyphosis, because most of the time you cannot get direct closure in the presence of severe kyphotic deformity. And in patients with previous or known risk of preterm labor or placental abruption or previous scar in the active uterine segment, they shouldn't be included in this study, or they were not included. And that's the basic technique as was highlighted in the previous lectures. But what's really important that the trial, as we've seen here, was prematurely stopped at 183 patients prematurely before the planned 200 patients due to the demonstrated efficacy. And this we can see here, the efficacy in the incidence of postoperative hydrocephalus in 68% compared to 98% between the prenatal and the postnatal. And after most of this hydrocephalus, or not all of this hydrocephalus, requires treatment. So we look at the shunt insertion rate at 12 months, or they looked at the shunt insertion rate at 12 months, 42% in the prenatal repair versus 82% in the postnatal repair, and also comparable results or superiority to the prenatal repair in the hindbrain herniation and in the mental development and the composite motor and gait function, or the composite score at 13 months. So there is demonstrable superiority, and we need to go for this way, probably adopt this technique. Probably we are encouraged by the development and the establishment of the fetal intervention unit at AHM's University led by Dr. Ayman and Dr. Mayan. But the thing is that we need to put something in mind. There is a risk of preterm labor that's reported in this study and reported in all other studies that reproduced the same technique. An average of about 34 weeks and more than 13% of the patients are born before 30 weeks of gestation compared to the postnatal repair. And there's an increased risk of wound dehiscence at the time of delivery. Similar studies or similar centers, in the post-MOMS era, particularly at CHOP, they also ran tests, or they ran studies retrospective this time to be able to see if the results are reproducible after the randomized control trial area. And they came up with a conclusion here at CHOP that in an experienced program, the maternal and the neonatal outcomes for patients undergoing fetal surgery or fetal repair could be comparable to the MOMS trial. At St. Louis, that was not a center participating in the MOMS trial, but Professor Samir al-Baba there is a big fan of the antenatal repair, and he used the same criteria. He had similar results, and in this paper he was looking at not even just shunt insertion. He was trying to avoid shunt insertion, and he did ETVs for most of the patients with a 45% success rate and shunt insertion rate which is less than the reported shunt insertion rate in the prenatal repair for the MOMS trial. There's another group also as well in Vanderbilt University, and they came up that there is, they were looking at the criteria for hydrocephalus as well, and they found that there's also the possibility that there is a form of permissive ventriculomegaly. You get patients after the prenatal repair, you get patients with hydrocephalus or ventriculomegaly, but you could not, or you don't have to treat them because they're not manifesting, and still they looked at the criteria and found very similar results. Prenatal repair was superior. So we can adopt this, but there are certain challenges that we need to put in mind. I don't think we can go for 19 to 26 weeks of gestation at the time of the enrollment or the inclusion. We need to think this over, because there is a risk of infection, there is a risk of membrane separation, placental abruption. Our fellows and our colleagues and professors in the obstetrics department and the fetal care unit will, fetal intervention unit will help us mitigate these challenges. But still, there is a risk of the preterm delivery, and without proper postnatal ICU, with the risk of neonatal sepsis, respiratory distress, and mechanical ventilation, we will ultimately end up with the risk of CSF infection, and there is brain damage in these kids. We don't want to do something. There is a risk which entails a risk of antenatal repair or a risk of preterm labor, and then end up with a kid suffering in the neonatal ICU. So we need to determine at first the age of the fetal viability, work on strict protocols to control the risk of neonatal sepsis, and improve the care in preterm infants. If we're going to do this, this requires a lot of training, and as Professor Ayman Abu Noor said, we need to go to the best surgeons or the best centers that need this. It's not about the technique, it's about the teaming up with high volume institutions with high flow and with a vision and experience to be able to have all the ancillary services and the different disciplines buying in and participating in this. After we do this, I guess we can go for a more complex thing, which is the fetoscopic repair, and that requires a larger learning curve. To my mind, if I can do open myelomeningeal repair, it could be less technically demanding than the fetoscopic repair. Thank you so much, and that's the end of it.
Thank you very much, Professor Asim. Now the floor is open for discussion.
Okay, we've enjoyed this session very much. It started very fruitfully from how to initiate the unit for fetal surgery, to expand the knowledge that it goes beyond what we expect. It seems that it's more complex, that the cases that are amenable for repair with fetal surgery is more than any specialty would imagine. So it seems that it won't grow linear, but it would grow rather exponential. So hopefully we see this dream coming true along the whole world to see that. Thank you, Professor Ayman Abou-Noor, for the initiative. Thank you all speakers for your input for this session. And perhaps anyone has any further comments or questions for the past presentations before. Yes, Dr. Karam.
I have a comment for Professor Asim. Do you have a preferable age for managing meningomyocele intrauterine? I mean, how far could you postpone the operation without any drastic effects on the baby or on the fetus?
Okay, thank you, sir, for this question. And honestly speaking, I don't have a correct answer in my mind. It's a matter of experience that we build up through the feedback and through the complications that we face. But one thing that I'm sure of, we cannot adopt the 20 to 26 weeks gestation that was reported by the MOMS trial. So as far as we can see, we can discuss with the neonatal ICU when is the proper age or the more suitable age for them to manage or to support a kid to be delivered and without the least possible complications. From interfacing with my colleagues at the neonatal ICU, they could go with the 30 weeks. So probably we can do the fetal surgery or the fetal repair 2 weeks ahead of it. So probably at the age of 28 weeks, this could be a good starting point. And we can take it from there and then see how the feedback or the results direct us.
Thank you. We conclude our session and now proceed to the next session, please. Thanks.